I now request Dr. M. Harish to come and deliver his lecture on Sepsis 2021, What's New.
Good afternoon. So thanks, Reflex, for having me here. So maybe in another 20-25 minutes, we'll try to understand what newer things happened in the sepsis in 2021. So basically, first thing we need to understand why every 4 years or 5 years we are going to have some new concept came in and it has been again like changed in the next coming years and all. So it is because we are struggling to have an improved like outcome in terms of morbidity and mortality. So even in the best of the best ICUs, the sepsis is having a mortality of around 35 to 50% depending upon what category of the patients we are treating. So timeline of the like admission to the ICU and all. So basically lots of things happened in terms of early diagnosis, what therapeutic intervention we can do, what adjuvant therapies we can do in sepsis septic shock to have a overall like reduction in the morbidity and mortality. So when it comes like newer things, we got a recent guidelines from Survey Sepsis Campaign 2021 guidelines. So I'm going to talk about like important aspects, what we got, some aspects changed, and a bit rationality behind that. Means like why they incorporated, why they changed kind of this one in 20 minutes. So basically, first thing we need to understand, we need our own some sort of performance indicators. Okay, so to screen a patient who is having a sepsis septic shock, so who is acutely ill and is having a lots of risk factor to have a possible or probable sepsis, that is very important. We need to understand where we are here, means like where we are going to be in the future in terms of our own data, to screen, to treat, to understand, to improve ourselves kind of this one that has been re-emphasized again in 2021 like guidelines as compared to that of the 2016 guidelines. So this is lots of like challenges, lots of changes happened in terms of diagnostic criteria. See, our concept was we are not having any reduction in the mortality. The problem maybe we are not identifying the septic patient in a timely manner. So they created in the last like sepsis 3 definition. So in 2016 and after that, so maybe we need to like concentrate more on the community screening of the septic patient and identification of the patients who are on the floor. So patient came for some sort of clear-cut surgery like appendicitis and all. So they got some sort of infection, how to diagnose? We have some sort of SOFA score, we assume. So admission SOFA is 0 and any SOFA score increased by 2 or more than 2, which is having around 5 parameters, we label them as having a sepsis kind of this one. So otherwise on a community based hospital, we have Q SOFA, so which included 3 parameters like respiratory rate, altered mental status and that of the blood pressure. But the problem is like when they introduced this concept of getting an idea, criteria to diagnose sepsis on a community basis, we have a problem because some patient who is like immunocompromised, having a bad mucositis, he came with a diarrhea, tachycardia, fever. So we are going to miss that patient. So obviously, again, this criteria has been criticized. So we had a newer criteria currently in 2021. So concentrate on something called early warning score or modified early warning score, because if you adhere to the criteria of QSOFA, which is having a GCS of less than 15, respiratory rate of more than or equal to 22, or systolic blood pressure of less than or equal to 100 millimeters of mercury. So only about 24% of the patients who are going to like have these criteria 2 or more. So and those patients who are going to contribute to high mortality, which is around 75%. And this QSOFA is having a more specificity, but the problem is less sensitive. When we have a problem with the sensitivity, there is a high possibility we are going to miss the patients and all. So that is not our goal. So we need to identify the septic patient and early priority. So in 2021, we had a recommendation against using QSOFA compared to the search criteria, news. But we know that like search is having its own limitation. So there is a very thin margin to have a differentiation between a search and that of the sepsis. A patient who had a search criteria like severe acute pancreatitis, or maybe post-transfusion reaction, so or maybe some sort of trauma. So all these things make confusion in identifying a patient with a like sepsis diagnosis and all. We need still more clarity, but this is, you need to remember, it is against that of the QSOFA. Again, like we had emphasis on the fluid bolus, means how much we give, 30 ml per kg. So basically lots of observational data we got, so which favored in terms of giving at least 30 ml per kg. So how we got this magic number 30 ml per kg of the fluid bolus? So observational data, and the data they analyzed three major trials like Process, Arise and Promise. So which clearly tells that against that of the early goal directed therapy, no need to specifically adhere to particular CVP, particular hematocrit. So it is individualized approach. So in a standard protocol is enough. So that data also suggests those patients who got well resuscitated, they had a like fluid of around 30 ml per kg. So suppose you need to individualize. So it is partially correct. Like you might not be the initial receiver of the patient. Patient might have already received like partial resuscitation in a like center where we got referred. So you have to individualize this approach. They might require more than 30 ml per kg, or they might require 25 ml per kg. So we need to individualize, but we should not miss that giving 30 ml per kg. So we need to understand again, it has been re-emphasized. So at least 30 ml per kg we need to give. In a patient is going to have ongoing signs and symptoms of hypoperfusion, or maybe like septic shock has been diagnosed. And they also recommended on the initiation of the oral early resuscitation measures, because they are not only giving an antibiotic, so each hour delay in the resuscitation is going to have an increase in morbidity and mortality. So again, next, like when we see the markers of our assessment of the resuscitation, so generally we use like biochemical markers that we use the lactate clearance and all those things. So this is one data. So why they rationalized and they re-emphasized on the utility of the clinical markers like peripheral perfusion, capillary refill time. So this is the rationality evidence for that. We got this Andromeda trial. So they compared basically capillary refill time versus that of the lactate, and it was comparable. So we can follow using capillary refill time as one of the alternative for the lactate clearance and all, to get an idea whether our resuscitation is going in a good way or not. So again they suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. So this is one more re-emphasized in the 2021 guidelines. So next is like how much to target MAP. So we already learned, okay, so this was one trial, the sepsis PAM trial. So this is the rationality again re-emphasized for a MAP of around 65 or more than that. So they compared the MAP of 80 to 85 versus that of 65 to 70. So those patients who are having only background of like chronic renal failure, CKD group of patients, in them we need to target a bit of higher MAP, maybe around 75 to 80 or more than 80 kind of this one. Otherwise, in general patient, if they don't have any CKD as a comorbid condition, definitely which is going to add to increase in incidence of arrhythmia without any changes in the mortality benefit. So target of MAP, again it has been re-emphasized. So of a MAP of more than 65 is going to be enough for all the patients who doesn't have any background of like chronic kidney disease and all. So next, like they re-emphasized early admission to ICU. If a patient had been diagnosed with a sepsis, don't keep the patient in the emergency department, because they have some sort of observational data, retrospective data. If you keep a patient in the ER beyond 6 hours, whatever the reason, maybe financial reason or maybe some discussion regarding the bed availability and all, each hour delay in admission to the ICU is going to increase the mortality by about around 1.5 to 2% kind of stuff. So they re-emphasized early admission to the intensive care unit, where we can fine-tune the monitoring, fine-tune the resuscitation, reassess and change the therapy on the go. So next is like diagnosing the infection and all. See, basically our assumption, so when a patient admitted to ICU, so like we think, so they have been already labeled as having a sepsis and all, but at each moment they re-emphasize, you look for other causes of the like some sort of the shock which is ongoing. So basically recommendation and timing the antibiotic. We know that Anand Kumar et al. They showed, so each hour delay in giving the antibiotic is going to increase the mortality by about around 6 to 8%. But on the other end, we don't have a data giving just an antibiotic is going to reduce the mortality. Okay, so giving an appropriate, okay, so timely given empirical antibiotic is going to save the life, not just giving an antibiotic. That's why, so giving an antibiotic in relation to timeline, so they have been tagged to the whether a patient is having a shock or not. The patient is having shock, so the sepsis diagnosis is definite or it is probable, so then it is advised to give the antibiotic within 1 hour. That is the appropriate early empirical antibiotic. The the patient is not having shock, then there is a possibility of the sepsis. It is not a probable or a definitive sepsis diagnosis. So then we can take a call and re-evaluating our patient. If the patient is really having an ongoing sepsis infection, so re-evaluate and upper limit to give an antibiotic maybe around 3 hours kind of this one. But shock is present, so sepsis is possible, then it is advised to give the antibiotic at 3 hours, so within 1 hour. So don't delay. 1 hour means as early as possible. It's not like you need to wait for an hour to give the antibiotic. So again, like can we use some sort of biomarkers to identify the sepsis? Answer is no. So because they identify the biomarkers like procalcitonin, we have lots of biomarkers like trisepsin, CRP and all, so which have a problem with the sensitivity, problem with the specificity. So one accepted biomarker is procalcitonin. But the problem is it is also not totally like specific. Even a patient with a pancreatitis, even a patient with a myocardial infarction, congestive heart failure can have increase in procalcitonin even with the background of like fungal infection or maybe viral infection and all. So there is no data to suggest clearly diagnose a patient so with the background of increased procalcitonin as having sepsis and all. So it has been clear. So you need to use like the clinical parameters to diagnose or label a particular patient with having sepsis or not. There is no data to suggest using procalcitonin to diagnose. So diagnosis based on the clinical parameter. This is again re-emphasized from the 2021 guidelines. So again, like can we give empirical anti-MRSA therapy? One concept was hit them hard, hit them broad kind of this one. That is not acceptable. When a patient is having neutropenic, skin soft tissue infection, maybe bad mucositis, very wide fluctuating hemodynamics, or is having a sudden spike of temperature of more than 40 degrees Celsius, and there is a cross reactivity, molecular mimicry, those patients who have influenza H1N1, there is a high possibility to have MRSA infection. So you need to risk categorize. Our patient who is having a colonizer with the MRSA, maybe sometimes what we do for our neutropenic patient is before the bone marrow transplantation, we do the surveillance culture. So from the groin, nasal cavity, perianal area. If that is being identified as the MRSA, we can give as an empirical therapy. MRSA agent may be synthetic or natural glycopeptide as vancomycin or mecobalamin. So otherwise, empirically to give anti-MRSA therapy is not acceptable. Again, routine usage of antifungal, so not advised in the 2021. That is, see in Indian scenario, in Asian scenario, don't bypass before like covering the gram-negative organism to jump on giving the antifungal therapy. So cover our own MDR, XDR gram-negative organisms. When you think about giving the antifungal agent, so depending upon the clinical profile, if the patient is having a TPM, like uncontrolled diabetes, post-hematopoietic stem cell transplantation, organ transplantation, so on dialysis, okay, so CKD patient, severe acute pancreatitis, we have the risk categorization, so then you can individually think about is the particular patient need an empirical antifungal or preemptive antifungal, so then putting them as like initial therapy with the antifungal and all. So definitely no role for putting antiviral for all the patient who had sepsis and all. So next is optimal antibiotic delivery. So this has been re-emphasized again, means like given a more highlight, consider the PKPD profile of antibiotics in a critically ill patient. See, we have a lipophilic agent, hydrophilic agent. Most commonly used agents are hydrophilic, particularly like beta-lactam group of agents and all. So when a patient is having an early sepsis, so they are going to have an increase in volume of distribution. So we need to concentrate something called front loading. Okay, we need to give a very good high dosage of water soluble agent, particularly glycopeptides and beta-lactams. And other thing we need to consider is like what is their pharmacokinetic profile. Are they concentration dependent? So then give a very good bolus dosage, but increase the interval, particularly aminoglycosides and all. We give a same 1 gram, but increase the duration maybe once in 48 hours in a renally compromised patient. If it is like time dependent antibiotics, we need to understand the concentration should be above the MIC during the interval at least for 40% of the duration. So we need to give an extended infusion of all the beta-lactam, including carbapenems, like penicillin BRBRI combinations and other cephalosporins. So that is being emphasized strongly in the newer guidelines, that is 2021. Consider PKPD profile, consider the patient profile in terms of the bolus dosage, duration of infusion and all. So they re-emphasize it again on the source control as early as possible. No need to wait for 12 hours also. In a minimally invasive possible way, we need to aggressively control the source. That is very important. So then I spoken about the use of procalcitonin, definitely not for diagnosis,
But there is a data so which back up the current guidelines to use procalcitonin for the de-escalation of antibiotics. This is one data so which got published long back in 2010. So they reconsidered this data. So we can use procalcitonin as an adjuvant biomarker along with the clinical criteria, along with the hemodynamic parameters to de-escalate the antibiotics. So they suggest using procalcitonin and clinical evaluation to decide when to discontinue antimicrobials. So there are lots of cutoffs has been like given, so 80% drop, 70% drop, and all, but they given a clear-cut idea. We can use procalcitonin for the de-escalation purpose, not for the diagnostic purpose and all. So again on the fluid therapy, so we have a lots of decade in the last 2 decades discussions on the crystalline colloid. We have chest Christmas crystal and the landmark trial which changed the therapy, that the Scandinavian success trial published in 2012. So we put a full stop for hydroxyethyl star, which increases the more chance of like kidney injury, renal replacement, and also increases the mortality and all. So then among the colloids which we can give little bit weightage is like albumin. We got a safe trial which shows no changes in the mortality when you use like 4% albumin versus the normal saline. But in the subgroup analysis, it gives some hint. So we can have some sort of the mortality reduction if you use albumin. So for a patient who had a severe septic shock and all, definitely not for a patient who is having a traumatic brain injury. So again, one more colloid, that is gelatin. We don't have a very good data to tell head-to-head comparison between gelatin and that of the other crystalline, other colloid. We have a accumulated meta-analysis, so that they given a full stop, so they don't advise the gelatin again in the issue and all. So among the crystalline, we have a balanced, unbalanced and all. So we have normal saline which cause problems, the hyperchloremic, normal anemia, metabolic acidosis. We know that chloride is going to cause renal vasoconstriction, more chance of renal injury, need of renal replacement therapy. So we got split salt ED smart. So smart trial in ICU clearly suggests that if you use normal saline, so more chance of morbidity in terms of the renal replacement therapy, in terms of major adverse kidney events like MAE. So salt ED in the emergency department, it is okay to give the fluid using normal saline, maybe around 1.5 to 2 liter kind of this one. Split trial they use like in most of the elective surgical like patient, it doesn't shows any sort of difference whether you use balanced versus non-balanced salt solution. So based on these things, again they given a guidelines emphasizing on usage of the balanced crystalloids instead of normal saline for the resuscitation. So again suggested against using gelatin resuscitation, because I told only we have accumulated meta-analysis or some sort of systematic review, not a head-to-head comparison with that of the gelatin. So vasoactive agent, this is the summary. First agent of option is going to be norepinephrine. So target a MAP of more than 65. Consider invasive hemodynamic monitoring, particularly dynamic indices and all. So MAP, if it is not possible to achieve the target of 65 or more than 65 with an norepinephrine, we can use vasopressin as a rescue therapy. When to fix the dobutamine? So if you documented patient is having a poor contractility, adequately filled, okay, with an ongoing hypoperfusion, lactate is high, capillary refill time is prolonged, so peripheries are cold, okay, so then we can consider using the dobutamine. Remember, it is after adequately filling. So still we struggle to improve the markers of perfusion, we can use the dobutamine. So is there any role of levosimendan? So with this backup of the data, that the Leopard's trial, so clear cut, no evidence to suggest usage of the levosimendan. The problem with the levosimendan, we know that it is a calcium channel sensitizer. So it causes some sort of peripheral vasodilatation to the potassium channel. Even though it improves the contractility, it is not a titratable agent. If you give levosimendan for a period of maybe 3 days, 4 days, its half-life is going to be a week. So we need an agent which is rapid onset, rapid offset, titratable agent in a critically ill patient, not an agent if you give, okay, we need to wait to like resolve its action and all. So with this trial, again, they concluded it is suggested against the usage of levosimendan in a septic patient who is having a septic shock or sepsis-induced cardiomyopathy. So next, like, are we having sufficient evidence to jump on the de-resuscitation in the initial 24 hours to diurese them? If a patient is still having an ongoing hypoperfusion, so 24 hours is not the cutoff just to consider some sort of de-resuscitation. If a patient requires fluid, even in and around the 24 hours, we need to consider giving the fluid. So there is no cutoff of 24 hours to recommendation to consider for the resuscitation and stopping the fluid bolus and all. So again, they emphasized a bit on high flow nasal oxygen therapy in a hypoxic respiratory failure because we know that NIV is more favored in terms of utility in the type 2 respiratory failure except in cardiogenic pulmonary edema. So NIV in community acquired pneumonia. So lots of data available failed utility. So they favored usage of high flow nasal cannula for hypoxic respiratory failure. Again, it is from the 2021 recommendation. So the given guidelines for ECMO in patient like those who are having a sepsis severe ARDS suggest using veno-venous ECMO when conventional mechanical ventilation fails in an experienced center with the infrastructure which is available for putting an ECMO. Remember, so it is after your conventional mechanical ventilation. You should prone them so before you consider starting them on ECMO because it is having its own cost implication in the Indian scenario. So again, like corticosteroid, I thought before we got these guidelines, they might consider putting a full stop for using the corticosteroid, but they re-emphasized on the usage of steroids, so-called with the background of relative adrenal insufficiency. So we got two major trials, there is the Ananya trial, Carticus trial. So they used in one of the Ananya trial, that is fludrocortisone, to have some sort of outcome benefit. Carticus trial again failed to show some sort of outcome benefit, but adrenal trial very recently we got doesn't show any difference whether we use hydrocortisone or not. But considering the pooled data, they suggested usage of corticosteroid. So in a patient with a septic shock and an ongoing requirement of vasopressor therapy. But here one good thing is the typical corticosteroid used in adult with septic shock is IV hydrocortisone, that's about 200 milligram per day, not more than that. So if you don't have a sufficient infusion pump, you can go for 50 milligram Q6 hourly. But only problem in giving the bolus is hypernatremia and hyperglycemia. Otherwise, there is no outcome difference at all. But the one good thing, they given some cutoff value. So norepinephrine or epinephrine, if it is more than or equal to 0.25 miles per kg per minute, so at least for 4 hours after initiation, we can consider giving the hydrocortisone. This was like previously asked a question, when to put the hydrocortisone. They given some number, so it may be 0.25 or 0.3 or maybe 0.2 also. So you need to remember all these things. So it is not like clear cut, we have to jump on using steroid after only 0.25 minutes. So what about filtering the sepsis? Like in the morning sessions also we would learn. So there are lots of things which we can do to save the patient in terms of extracorporeal therapy. So we call them as a filtering of the sepsis and all. See, this is particularly for gram-negative organism. From the liposaccharides, they release the endotoxin. So they will act on the cells, they release the cytokines. So cytokines will act on the receptor. We have three targets. One is take care of the endotoxin itself, take care of the cytokines after they act on the cells and all, or block the receptors of the cytokines. So extracorporeal therapy, either they targeted the endotoxin removal, that is the initial step, or maybe cytokine release kind of this one. Some filter they are going to target both removal of endotoxin and that of the cytokine. So there are lots of data available in one therapy, that is a polymyxin adsorption, that is using chloromyxin, that is meant to endotoxin lipopolysaccharide removal. So we had two important trials to back up this rationality. UFASL trial, so they targeted in a patient who had abdominal infection, which showed a very good outcome benefit, but the data was very small, hardly 34 patients. Later we had Euphrates trial, so 28-day mortality, the good number of patients failed to show any sort of outcome benefit. So what is the recommendation from the 2021 guidelines? So suggest against using polymyxin B hemoperfusion filters and all. We need some more data, but lots of things evolving in this field, like filtering the sepsis, we need to look for this space. Again, major magic bullet. So what about like guidelines? There is a Murray protocol, used high dose of vitamin C, 1.5 gram to 6 thoroughly. We have like after this Murray trial, citrus honey, vitamins trial, orange trial and all. So considering the pooled data, they suggested against the usage of the vitamin C. So this is at least you need to remember for the guidelines sake. It is an individualized thought process, believers versus not believers. But when someone asks what is the guidelines 2021, so it is against the usage of vitamin C. So other than this regular therapy, they concentrated more on the palliative care. So when to involve, so don't involve any palliative care support for all the patients. When it is needed, they strongly emphasize to use the palliative care consultant and all. So peer support group to support the family and other caregivers we need to involve. So they again put a more like guidelines highlight for all these things. transition of care. So we need to give a particular hand-off process, okay? But they are not recommended which one to follow and all, but written hand-off, like proper transition of the care should be given while giving the handover and all. For economic and social support, that is very important in our tertiary care, like ICUs in Indian scenario. So one major like component when it comes to care of all these adjoint, so like therapies, like including the extracorporeal therapy, is the cost. We need a economic and social support, counseling and discussion in and around. That is again emphasized by the 2021 guidelines. So sepsis education, they given a concentration to public awareness. When a patient survived, came out of the ICU, ready to go home, give an information in terms of the education to the like supporters, family, caregivers, okay, so relatives regarding what happened in the ICU and its impact, what precautions they need to take in the community to prevent again further septic events and all. So shared decision making, this is for the discharge criteria, overall involved in giving the care. Maybe a neurologist, maybe a endocrinologist, you need to take them into the single consensus when you make the decision for the discharge and all. So discharge planning, one important thing you need to consider, so reconciliation of the medication, what patient was already on the like prior to admission and all. So again, what happened in the like ICU, you need to give proper like idea what therapy you have done, what additional things you have done, whether patient gone for ECMO or you used any sort of adjunctive adjuvant therapy and all those things should become in the discharge plan, discharge summary and all. Post discharge follow, so need some sort of physical, cognitive, emotional support after discharge also. They also re-emphasize those patients who had a mechanical ventilation of more than 48 hours, ICU stay of more than 72 hours, so referral to a post-hospital rehabilitation program. It may not be always possible in Indian scenario, but one thing we need to remember, so all these leftover things, all these like public awareness, discharge plan, so giving the handover, like palliative care, they emphasize strongly in the like 2021 guidelines and all. Thank you all. Any questions?
In case of septic shock, the patient is on non-explosive and a vasopressin, it should be stopped last. In case of septic shock, patient is on non-explosive and vasopressin, it should be lost. It should be stopped last.
Basically, you titrate like norepinephrine to the lowest possible and all. Try to stop the vasopressin. Suppose if the patient requirement of norepinephrine is not more than 50% from the baseline, you can consider bit of more dosage of the norepinephrine and you can try to be on.
Vasopressin first or non-explosive first?
Yeah, you can titrate and stop the vasopressin and you can tail off the norepinephrine later. Basically, there are lots of concepts for vasopressin why we need to start. There is one concept is like as a rescue therapy for receptors failing effect and all. So norepinephrine being act on the alpha receptors and all. So this acts on a different receptor. So by that time, if the receptors got recovered, so then you can consider stopping the vasopressin and you can take a call. But there is no clear-cut guidelines. Okay, which one to stop? So you need to titrate and see this. It is again a relative vasopressin deficiency. That is very difficult to get an idea and put a gross guidelines for that. It is individual response. Some patients have been categorized as a vasopressin responder. In them, it is better to keep the vasopressin till the end. If they don't show vasopressin good response, then you can cut down the vasopressin. Keep on giving adrenaline, means like norepinephrine, or you can consider adding epinephrine to that.
Thank you, Dr. Harish. Not an easy topic, but he has explained it very beautifully in quite good detail. Thank you.
Thank you very much, College.